Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about Stasis Dermatitis. Definition: Stasis Dermatitis is an eczematous eruption of the lower legs secondary to peripheral venous disease. Venous incompetence causes increased hydrostatic pressure and capillary damage with extravasation of red blood cells and serum. In some patients, this condition causes an inflammatory eczematous process. Stasis dermatitis, dusky red scaling crusted plaque. Epidermis is thickened and hyperkeratotic, and in dermis perivascular inflammation can be seen. Incidence: Stasis dermatitis is a disease of adults predominantly of middle and older age. History: Patients have a history of a chronic pruritic eruption of the lower legs preceded by edema and swelling. Patients with stasis dermatitis have often had thrombophlebitis. Physical examination: varicose veins are often prominent as is beading edema of the lower leg. The peripheral pulses are intact. The involved skin has brownish hyperpigmentation, dull erythema, petechia, thickened skin, scaling or weeping. Any portion of the lower leg may be affected, but the predominant site is above the medial malleolus. Characteristics of stasis dermatitis include edema, brown pigmentation, petechia, subacute, and chronic dermatitis. Differential diagnosis: contact dermatitis, superficial fungal infection, and bacterial cellulitis must be considered in the differential diagnosis of stasis dermatitis. The history of application of a topical preparation of the skin and potassium hydroxide testing will help to differentiate the first two conditions from stasis dermatitis. Gram staining and bacterial culture from bacterial cellulitis may be helpful but are often negative. An acute onset with fever particularly favors bacterial cellulitis. The conclusion of differential diagnosis of stasis dermatitis include contact dermatitis, superficial fungal infection, and bacterial cellulitis. Laboratory and biopsy: the diagnosis of stasis dermatitis is usually made clinically. The biopsy shows a subacute or chronic dermatitis with hemosiderin, fibrosis, and dilated capillaries in the dermis. Vascular laboratory studies may be used to assess for peripheral vascular disease. Therapy: the cornerstone of stasis dermatitis management is the prevention of venous stasis and edema. This is done by the use of compression stocking while the patient is ambulatory. Standing should be restricted, and patients who are obese should be placed on a weight reduction program. If this approach fails, bed rest with elevation of the leg is required. The dermatitis skin is treated with topical steroid and wet compresses like Domiboro if oozing or crusting is present. Therapy for stasis dermatitis: initial therapy includes support stocking, knee height to 20 to 30 mm Hg pressure, leg elevation, topical steroids, compresses if whipping, and alternative therapy include una boot and surgery. Course and complications: stasis dermatitis is a chronic and slowly progressive disease unless treated. Dusky erythema in areas of stasis dermatitis is the harbinger of a leg ulceration. Allergy to topical preparations may occur in 60% of patients with stasis dermatitis. The compromised epidermal barrier from stasis allows sensitization to occur more easily than in normal skin. Contact dermatitis can easily be misdiagnosed as a flare-up of stasis dermatitis. Topical antibiotics are particularly prone to cause allergic contact dermatitis. Note: avoid the prolonged use of topical antibiotics since allergic contact dermatitis is frequent. Key points of stasis dermatitis include eczematous patches or plaques, underlying lower leg edema, chronic and itchy. Treat venous hypertension with compression stockings. Pathogenesis. Venous incompetence results in increased venous pressure of the lower legs. This increased hydrostatic pressure results in swelling and edema. Capillary proliferation and leakage of red blood cells and vascular fluids result in inflammation. If the condition is unchecked, fibrin deposition will occur around the capillaries, resulting in tissue hypoxia, sclerosis, and necrosis with ulceration. Clinical case. A 68-year-old man presents with chronic redness, itching, and scaling of both lower legs for the past several months. He has a long history of chronic venous insufficiency and varicose veins. He reports that the skin changes worsen toward the end of the day after prolonged standing. On examination, there is bilateral erythema, hyperpigmentation, scaling, and mild edema around the medial ankles and lower legs. The skin appears thickened and there are areas of brownish discoloration. The affected areas are warm but not tender. He is afebrile. Which of the following is the most likely diagnosis? A. Contact dermatitis. B. Superficial fungal infection. C. Bacterial cellulitis. D. Stasis dermatitis. And E. Atopic dermatitis. According to our explanations, the diagnosis is Stasis dermatitis. Explanation. Stasis dermatitis results from chronic venous hypertension and pure venous return. Typical features include bilateral involvement, lower legs and medial malleoli, erythema, scaling, pruritus usually is present, and brown hyperpigmentation is because of hemosiderin deposition, associated edema, and varicose veins. Symptoms worsen with prolonged standing and improve with leg elevation. While the others are less likely, contact dermatitis has acute onset with a clear exposure history, vesicles, and intense itching is usually present. And superficial fungal infections present as annular lesions with active scaly borders and central clearing. And bacterial cellulitis is unilateral, painful, tender with fever and systemic signs. Atopic dermatitis has chronic relapsing eczema with flexural distribution, often from childhood. Okay, this was a short explanation about stasis dermatitis. Thank you for your attention.